Good morning, everybody. Thank you for joining today's seminar on PM2.5 specific reduction in life expectancy across 2 time periods and identification of race, ethnicity, and vulnerability. I'm the contract manager. I will go over a short background on the study at first, and then the PI will go over the project presentation. We have few housekeeping tips. The slide decks and the recording will be posted at this website. Please make sure to mute yourself. If you're not speaking, you can use the chat box to enter your questions. You can raise your hand and I can unmute you so you can ask any question you want. But we want to let you know that the comment period for verbal comment is only 3 minutes per person. If you're calling in, you can send question to my email. We will handle the question and answer at the end of the presentation. For today's agenda, this is the short background of the study I am giving right now. And then after that, the research team will go over the project presentation and we'll handle the question and comments at the very end. Even though PM2.5 concentration have declined substantially over the past 2 decades because of regulatory and technological progress, PM2.5 continues to be a significant public health burden in California. Long-term exposure to PM2.5 is well established as a contributor to premature mortality, but relatively few studies have quantified life expectancy impact, and fewer have examined how both mortality risk and life expectancy impact can evolve over multiple decades. Almost there is no prior research that has evaluated how these impacts may differ by age group, race, ethnicity, or whether the effects are concentrated in younger or older adults. To fill in these gaps, this study has quantified PM2.5 attributable mortality and life expectancy impacts across 2 decades in California. In addition, the study examined differences across race, ethnicity, and age groups to assess subgroup-specific burdens and how these patterns may change over time. Researchers also mapped life expectancy impacts at the census tract level throughout California to see if PM2.5 effects has varied in vulnerable communities over time. This study provides CARB with one of the most comprehensive evaluations to date on how PM2.5 affects mortality and life expectancy across age groups, race, ethnicity groups, and communities in California, and how these impacts have changed over 2 decades. The results show that PM2.5 control continues to yield public health benefits, but achieving equitable protection for all Californians requires maintaining statewide emission reduction while also targeting local areas and demographic groups with remaining high impacts. Together, these findings underscore both the success of California's air quality regulations and the ongoing need for focused policies to further reduce PM2.5 attributable mortality and address the remaining disparities. Dr. Su is the principal investigator for this research. He is a senior researcher and principal investigator in the School of Public Health at the University of California, Berkeley. Dr. Su has experience in GIS, remote sensing and programming skills to process large scale of land use data, and he has also experience in mathematical and machine learning algorithm for environmental exposure modeling. He applies machine learning model and his biostatistics analytical skill in environmental epi studies, especially in modeling rescue medication use with data collected through smart inhaler sensors. So that concludes the short background on the study. Now I will turn over to Dr. Jason for his and his team for the presentation. Okay, I will go ahead and share his slides.
Thank you, Nargis. Thank you for the introduction. Thank you, everybody, for participating in today's final presentation of our COPPA project, 22RD011. So that's the association of PM2.5 with life expectancy. So we did it basically use all the data we could possibly get going back all the way to 1990. So we basically did two time periods. One is from two time periods. One is the 2000 to 2011 and 2000 to 2011 and from 2011 to 2021. So so that's the longest we could ever get for using the population data for life expectancy and research. So can you go to the next slide, please? Okay, and the project had 7 tasks. So first one is the literature review that's mainly conducted by Dr. Lee from UCSF. And then we also did the developing daily pollution services for PM2.5 from 1981 to 2021. After we did that, then we obtained CDPH mortality data from state CPHS and also a user agreement with CDPH, get the data what we wanted. Then we did the main task is calculating the PM2.5 impact on life expectancy and compared the impacts across 2 time periods to see how much improvement it has done over those 2 time periods. We also identified race-ethnicity disparities across those 2 time periods. Then the one thing is that because the COP wants to us to identify the local or small area variations of those disparities might exist. So we created GIS maps at a census tract level for 2 time periods and compared to improvement and also the locations with concerns. So that's a GIS map. We also involved RAMP, that's Joe's group, addressing the community's concerns on pollution and life expectancy. So we also did quarterly reporting, and now today we are doing the final presentation for our project. Next slide, please. Now, this is a literature review. The first part of the research is conducted mainly by Dr. Lee's group at UCSF. Now I'm turning the presentation to Dr. Lee.
All right, thank you, Dr. Su, and thank you to CARB for commissioning and supporting this really important and interesting work. I'm a physician and a geriatrician and a researcher at UCSF, and my expertise lies in systematic reviews, meta-analyses, and quantifying life expectancy for patients with various degrees of frailty and comorbidity burden. So I had the task primary lead of doing the literature review of air pollution on life expectancy. And then we focused on 3 types of air pollution, the PM2.5 and nitrous oxides and ozone, and then looking at life expectancy and of the air pollution in concert with the other common factors that drive life expectancy, such as chronic disease and social determinants of health. Next slide. So we worked with our medical librarian and a very enterprising medical student who is now a first-year intern at in Boston to devise our systematic review, focusing on our exposure of air pollution and specifically, again, to PM2.5, NO2, and ozone. Our outcome of interest was life expectancy, and we looked at a variety of other factors that previous studies have shown to be strongly related to these factors like cardiovascular disease, lung disease, asthma, COPD, diabetes, as well as kind of the more social versus the medical factors, including social determinants of health, race, ethnicity, socioeconomic status, and other vulnerable populations, such as those having different types of insurance and demographic factors. We looked at a variety of different statistical models from these previous studies, various types of regression, as well as random forests and other machine learning methods. And then we're looking at all studies published after year 2000, and we focused our review for those articles written in English. Next slide. And so, as usually happens in systematic reviews, the automatic review kind of leads to many articles being found. And then we initially did a title screening and then an abstract screening to come up with a final list of articles that we looked at in detail. So some of the things that we looked at that we decided to not include. So some of the excluded studies focused on, for example, PM10, focused on things like indoor air pollution or time-limited or acute events such as wildfires or dust storms. Other things that we looked at that specifically we did not include because they were outside of the scope of this project were things that were very cause-specific mortality. So if a study was focused just on lung cancer mortality, for example, or cardiovascular mortality, or mortality during the COVID-19 from COVID-19 causes, those were excluded as well. We also excluded studies that did not focus on mortality but morbidity, such as requiring hospitalizations or just disease incidents. We also excluded studies that focused on the very young, such as newborn and birth outcomes only. Next slide. So again, as we slowly kind of looked at all the studies that we've got automatically, and then looked at the titles and abstracts, we slowly excluded more and more of the studies, and ultimately we ended up with 38 studies after the full text screening. Next slide. So this is your standard diagram of how various studies were identified and why various studies were removed. So you can see using our structured queries, we initially identified 4,972 studies through various online resources, and there were over 1,000 duplicate records, which were excluded. And then after looking at the titles and abstracts, specifically focusing on the inclusion and exclusion criteria, we were able to exclude 3,572 of them. And then we reviewed 192 articles, reading the full text, and then excluding those when the full text screening revealed that many of these studies satisfied the exclusion criteria, leading to the 38 articles and the final analysis. Next slide. So we've been able to look, our systematic review has sent out for peer review and was accepted. We are in the process of getting that out in the journal Air Quality, Atmosphere, and Health. The title is The Relationship Between All-Cause Mortality and Air Pollution, Systematic Review Focusing on Vulnerable Populations. Next slide. And so this is the, it's a table with 30 one slides focusing on the PM2.5 air pollution and the association with all-cause mortality. This is too much for probably anyone to really look over, but I'll just point out. So this is put in order of year, and so you see the first name, the last name of the author, and the year that it was published. You also see how big some of these studies were. Sometimes, as small as several thousand, but sometimes as big as many millions. And you can see the varying levels of PM 2.5 and what the risk of increased PM 2.5 was. And looking down, I think the thing that I would point out is the fact that all of those relative risks or hazard ratios are above 1. So not surprisingly, as air pollution goes up, people's risk of death increases. And the final column, which I think is also important, is looking at the various things that the study tried to account for. So things like age, as well as gender, as well as various socioeconomic factors were all accounted for. And despite those things, the relationship between PM 2.5 air pollution and the mortality risk increases. So again, if you look down the fourth column from the left, the all-cause mortality risk, you see that the hazard ratios or relative risks range from 1.01 to 1.19 per 10 micrograms per cubic meter increase in PM 2.5. Next slide. And I think this is where I hand it back over to Dr. Su, because this is task 2, which he led.
Thank you, Dr. Li. That was a very good demonstration of what you have done. Excellent job. But I only want to focus on one, because this product is about PM 2.5 association with life expectancy. So the table 2 you provided says everything for what people have done previously. Basically, the PM 2.5 is significant for most of the studies associated with mortality risk and life expectancy. So now for this study, we are doing it statewide, right, across around 30 years. So or to two decades, I could say. For us to do this, we need to have air pollution data across those 2 decades. What we did, we first identified the factors that might impact levels of pollutant concentration or PM2.5. So this includes the sources, but also might have the sinks. Sinks are the ones without sources of the pollution. So for us, we include traffic data, land use data, like industrial, the commercial, those also have the impact too. And the liner cover data, like vegetation, might have impact as a sink to levels of concentration. And for this ones, they're in very high spatial resolution. We use around 30-meter spatial resolution. So we used buffers. We created buffers from 50 to 5 kilometers for them to identify potential ideal distance of impact on merged concentrations. Then we have this non-buffered remote sensing data. This include meteorological data, 2 weeks vegetation index, and also the aerosol optical depths data from NASA. We also have the ozone monitoring instrument data, and also plus some supplementary data like the digital elevation model. Is basically we assume when you have higher elevation, you will have lower concentration, and also the distance to roadways, distance to ports, and also the location category. So those are the main impact factors we consider that might have impact on levels of concentration of PM 2.5. Next slide, please. So once we identify those potential impact factors, then we used kind of a spatial temporal modeling machine learning algorithm called DSA. It's deletion, substitution, addition algorithms to build the model across the entire California. So you might already know what is 90 user regression models is to predict concentrations using the government monitored data, right? But that's the model. But our main goal is to predict the concentrations at the locations we don't know. So this is called a 90 user regression model. What we did is very unique. Is try to reduce the uncertainty of the prediction. We use V-fold, basically the 10-fold evaluation method. So in this way, we separate the data into 10 folds. Each time we use 9 folds of data to make a prediction, use the other fold not in the model to identify the accuracy of the prediction. We go this 10 times, so each fold will be used as a validation for the accuracy of the prediction from the other 9 folders. So we average the accuracy that then get the overall prediction accuracy of the model. The DSA model can have non-linear effects being considered, but for us to simplify, we only use linear effects. And also we did not consider the interaction effect, even though the DSA algorithm allows interaction effects. So basically we estimated PM2.5 levels across all the government, historical government provided, that's COP provided or being available, plus the Google area data, what we used for prediction, and also build the data for entire California over 30 years. At a very, very high spatial resolution. Those models were built at a 30-meter spatial resolution, but for the storage space, we used 100-meter resolution for final products. Next slide. Okay, these are the government regulatory PM2.5 monitors. This 340, that's all the government regulatory monitor on PM2.5 had throughout the entire monitoring history we are known. So across the major California regions, for sure, it is more focused on locations with more populations like SoCal, Los Angeles, and also San Francisco Bay Area. But also the Central Valley have significant monitoring too. Next slide. So in addition to the government regulatory monitoring, we also use kind of saturation monitoring data from Google Air mobile monitoring. For over here, we want to reduce spatial autocorrelation. So when we use the location allocation algorithm selected 4 regions in California, each region selected 150 road segments. Each region have those ones from many traffic corridors, those places allows trucks, and also the city roadways, but also those ones very far away. I mean the 500 meters away from the traffic corridors. So in this way, we we select those 150 road segments for East Bay, Central Valley, San Francisco Peninsula, and LA. So the total is 600. Next slide, please. Okay, so you can see for regulatory government monitors, we have 340. Google Streetcar measurements 600 road segments, but the total observations is more than 600,000. That was because for regulatory monitors, so only 340, but across many days, many years. So that's why there are so much data. So Google Streetcar is only each one of them only a season of something. So not that many. Over here, because the purpose is to identify the local variations of pollutant concentrations, we didn't add those like everybody probably knows that PM2.5 concentration might have an impact on regional, right? We could add the regional indicators like different air districts. We could easily increase the adjust R square to 0.75 or 0.8, but we didn't do that. The main point or purpose was to identify localized impact or association or gradients for PM2.5. Even though the adjusted R square over here is 0.65, when you consider association was more than 0.8. Okay, next slide. So this is the comparison of the modeled concentrations at the sensor track level. You can see if you just use your visual eyes, you can see from 1990 to 2020, the levels of concentration for PM2.5 reduced significantly, especially from 1990 to 2000 and 2000 to 2010 have smaller reductions, but still you can see the reductions. Once you go to 2020, the levels are further reduced. But there are some of the minor places, like the Central Valley, especially the Central King Valley, the level of reductions are very smaller. Basically, you can see the high spots, and also some of the places close to the borders, probably due to wildfire or other impacts. So this are the level of the concentrations throughout the history are used for time windows at the sensor track level. Next slide, please. Okay, the summary of PM2.5 non-use regression model development. So we used what the potential predictors we could think of that might have impact on PM2.5 concentrations. So we integrated not only the government regulatory monitors, we also used data from the mobile station monitors to have greater spatial coverage. So as I said, the molecular concentrations, the prediction power is around 65.3. So finally, we generate 100 meters spatial resolution daily services across entire California. So for anybody want to use this data, we need to figure out a way to share with the COP because the data is too huge. I think probably 7 terabytes of data for PM2.5. That's the size of the data to share. Next slide, please. Okay, now we've done exposure or the concentration part. So now we need to get the health data. For us, we applied access to the data first with the CDPH, right? We signed the agreement with CDPH and also provided what the data source, what is the type of data we wanted. Then we also applied for any state department data like CDPH or ArchPIT, you need to apply for state CPHS IRB application. So that's the Committee for Protection of Human Subjects. We also went through that. Then after those are signed, the UC Berkeley applied for IRB reliance to the state IRB before we could get the data. Next slide, please. Okay, so basically we acquired the demographic information like the age, sex, race, ethnicity, and also date of birth, but also data of death and the cause of death. And also we have like the location information, that's the key. Before early years, we don't have the like census tract information we could use to use as a location. But later years, like period 2, we use the residential street address. So that's the data. This is only have 2 slides, right? But it's a very, very tedious work. It involves 8 to 9 months of effort to get the approval from CDPH and also state CPHS and also UC Berkeley IRB reliance to get the data. But we got huge amounts of death data, millions of them, because it's all the deaths from 2010 to 2021. Next slide, please. Okay, now the fun part is to identify the impact or associations of PM2.5 with mortality and life expectancy, right? So,
okay.
So whatever we do, it doesn't matter for the entire period from 2000 to 2021, or for each specific time period, period 1 and period 2, we always use entire population, including entire death population. So our method is first estimate PM2.5, eliminate it. That means the life expectancy without the PM2.5 impact. Then we estimate estimate the PM2.5 life expectancy due to PM2.5 impact. And then we estimate for the entire period, but also each period specifically. I will talk about what specific period, each one of them. And also the improvement from one period to the other period. We also deal with race-ethnicity and the community level analysis. Next slide, please.
It's not progressing.
It's not moving.
Oh.
To the next slide.
Okay.
Oh yeah, thank you.
Thank you. Sorry.
Okay. Now specific study design is that okay. We separated the mortality data into 2 periods. One's from 2000, 2010. That's 11 years, and also from 2011 to 2021. That's another 11 years. So for us, for those people who are familiar with life table calculations, you need to have reference population. So that means age group, race, ethnicity specific for each period, how much population, total population over the year. For us, because we want to see the difference between period 1 and period 2, right? We do not want to have 2 different reference population. So we only use every 5 years of the data from census to use it as reference. So the baseline is fixed for the reference population. We use every 5 years to get the mean and get the overall reference population for our life expectancy estimates. And like I say, this population is basically the CDPH data, what we acquired from state. And we basically use that data to summarize or get estimate a total deaths for each age group, each race ethnicity. Also, this one, when we say we need to get the PM2.5 impact, in that way, we need to develop logistic regression models for each age group, each race ethnicity. So there's a lot of logistic regression models for over here to identify the PM2.5 impact, and then use each of those models to identify the PM2.5 impact on life expectancy. So in that way, we need to find the controls for each death. Somebody died at a specific day. We used the people, even though all of them are from mortality data from CDPH, right? We still identify those people are not died at the time of the death of that individual. Use data, the same data of birth plus the same sex, the same race ethnicity as control. So identify the impact of PM2.5. For the exposure, for each person died at a specific day, we used 1 year of exposure before death. So that's the level of exposure we used. We also excluded people that sometimes you have exposure misclassification. You do not go over to some place died at one location, but you might spend the majority of time somewhere else. So we used condition for each person died. You must have lived in that county for more than 1 year to reduce exposure, potentially reduce exposure misclassification. As I said, we developed a lot of logistic regression models that's basically for each group, each race ethnicity, what specified for the model. Then we used typical life table method and also area under the curve to show the impact or association of PM2.5 with life expectancy. So this is the study design. Next slide. Okay, this is some equations. I don't want to get it too complicated. So this is a basic life table method, but we added the impact of PM2.5. So for any age group, like you say, okay, 85 to 90 age groups, right? What's the mortality rate? That's easy. So how many people died in that age group? And also what's the overall population, reference population over there? So you have the mortality rate, right? But the baseline probability of death for that age group, like 85 to 90, you need to consider the width of the age group. That's you have NI over there. NI is the width. That's why when you have the NI is different, you have sometimes those kids, medium-aged people, old adults, then your NI would be different. Then the entire the baseline probability of death would be different, right? Okay, once you calculate the baseline probability of death, then you calculated the number of survivors at the beginning of each interval. Like if you say, okay, at 0 to 5 age group, the survival is the whole population that's capitalized L0, right? But if you go 85 to 90, so it is for that age group, then you have what is at at beginning of the 80 plus 1 minus QX, that's basically LX at 80, number of survivors, 80 times proportion being survived. Then so you got that, yeah. So, but in another way, when we do the try to find the PM2.5 association, as I said, we have a series of logistic regression models. Each model models the probability of death due to PM2.5 exposure. So we have coefficient beta 1. See over there, beta 1 is associated with each age group. If we also have race ethnicity subcategories, it is also associated with each race ethnicity. So you take the exposure, then you get a relative risk. So, so baseline probability of death then is adjusted through the relative risk association with PM2.5. So you have QI hyphen. Right? Once for life table, you have LX plus 1. And similarly for counter factual survival with PM2.5 removed is LX hyphen. So it's survival to the age of X. So it's due to removal of PM2.5, you have LX hyphen. So that's similar in a way to the typical life table. Go to the next slide. Okay, so then you calculate the same thing. We're going to life table method. Okay, but one is with PM2.5 removed, another one is just everything. It's all cost. So we have person years lived, LX in certain age group. You just use the beginning and ending number of people survived divided by 2, add up divided by 2, right? And then you once you calculate everything for a certain age, you calculate, okay, or age group, you calculate cumulative person years lived. You just add later ones, you're still over there. That's the TX. And the TX hyphen is basically the ones PM2.5 will be removed. And then you get a life expectancy, right? And also the impact on PM2.5 is the PM2.5 removed EX hyphen minus EX. Okay, you could have questions later, or we could discuss if you have interest in our research later. So that's how my life table being used, and also for us incorporating impact of PM2.5 on life expectancy. Next one. Okay, for this, the life expectancy loss due to PM2.5 is the E0. That means E0 hyphen minus E0 as what I have shown you before. But we also compared 2 periods, period 1 to period 2, and also race ethnicity subgroups. We also built we also built area under the curve to show visually how the impact of PM2.5 at each age group. Then during our calculation, we have some key constraints. For each individual, if you have no health issue, no any impact, no air pollution impact, your maximum is 130 years old. Because for us, we excluded some of the data, like some people due to not living over there for 1 year, more than 1 year, and also those people moved quite a lot. Other factors, the estimated the life expectancy when at a starting point might be slightly different from California specific life expectancy. we made minor adjustments. Those are very minor adjustments to align with California specific life expectancy. And for each age group impact, because sometimes PM2.5 coefficient can be big. The impact could be more than 1 year. We limited based on maximum impact of life expectancy at each age group is 0.95 years. So this is based on literature review results. Dr. Autumn Pope has this values. So we just use the literature review results. That's the maximum impact for a specific age group. Next slide, please. Okay, for PM2.5 exposure, you can see on the left side, I have period, right? One is period number 1, another one is period number 2. We focus on period number 1 first. You can see the Hispanics has the highest mean exposure. Then it's the non-Hispanic Black, and the white, non-Hispanic white has the lowest exposure. When we go to second period, this pattern remained. But one thing you can see is that level of exposure reduced from period 1 to period 2. Next slide, please. Even though the gradient still exists, okay? Now I'm showing you some of the results. Now we'll try to explain as simple as I could, okay? So throughout the entire period, okay, from 2000 to 2021, without any race ethnicity stratification, but because we need to have logistic regression models for each age group to identify the PM2.5 impact for that age group, right? So we built the logistic regression models. You can see on the left side of the figure, all of the age groups are significant associate of PM2.5 with mortality. All of them. None of them are negative. So I maintained coefficients over there because we want to use the coefficient to take EXP exponential and then EXP to get the relative risk. So that's the association. But when you convert that to relative risk, incorporate that into the life table calculation. So you can see on the right side, the orange ones are the ones all cause. So basically, it's a typical life table calculation. But the right side, the blue one is those ones with PM2.5 eliminated, as I showed you before. And also I put the numbers over there on the top. That's the impact of PM2.5 on life expectancy for each age group. My eyes are not that good. So basically range from 0.16 to 0.95. Right? So this is overall without any race ethnicity stratification, without any period separation. This is the overall result for entire. Over here, another thing I want to focus. We use all the best data as long as the data meet the criteria. This is not a small sample size. This is a huge sample size across many years. Okay, next slide, please. Okay, now we are going to go to 2 periods now. Okay, period 1 is from 2000 to 2010. The association is still positive for every age group. And then calculate the life expectancy. The impact of PM, I'm I assume I will already explain some part in the previous slide, so I'm just jumping forward. Say the impact right now is PM2.5 impact for period 1. It's basically from 0.29 to 0.95. Over here, you can see one thing. Okay, for the period 1, for the old age groups, they have higher impact on life expectancy, right? You can see the associations are also higher. Okay, I point this out because once we go to the second period, it will, the pattern might shift. Go to the next slide, acknowledges, please. Okay, so now you can see, go to the second period from 2011 to 2021. Okay, the younger generation still lower, but younger generation has relatively higher association with PM2.5. The older adults, the associations became weaker, and also the younger ones have a higher confidence interval that probably shows less people died at a younger age group, but the associations relatively are higher. You can see for the impact on the right side of the figure is from you have 0.57 of impact age group. Once you go to later ones, they are not that big, right? Okay, so that's it's okay.
Okay, sorry.
So that's the shift from period 1 to period 2. We all knew that the levels of concentrations reduced significantly from period 1 and period 2, but the pattern over here, the impact also changed from period 1 and to period 2. Just want to you to know. Next slide. Okay, when we do the race-ethnicity stratification, then because of the sample size getting smaller, we used 5 age groups. So you can see, except over here, for the Black younger age, since they do not have significant association or do not have a positive association with the PM2.5 for mortality risk, and also the other age group for the very old ones. For those 4 other ones that still showed positive and significant associations with mortality. Next slide, please. Okay, this the same thing is very under the curve, and the impact, like this is similar to the associations, right? Most of them have significant impact. PM2.5 eliminated more or greater than all cause, except for the Black the 2 age groups and also the other 2 age groups. So majority of them still show the impact of PM2.5 on life expectancy. At the lower 1, 2, 3, 4, 5, 6 number 6 subfigure, I'm not sure you can see screen the impact. So mostly the impact is positive from PM2.5, except Blacks, due to the younger age groups not showing the positive association. For other ones that still have the impact of PM2.5 impact on life expectancy. Next slide, please. Okay, this is similar to the first period. So now it's for the second period, right? It shows similar. So there's some differences, but still showing largely impact of PM2.5 on life expectancy for the age groups across different race ethnicity subgroups that's significant for majority of them. Go to the next. Okay, these are the I read the undercurve method. So for those ones, if you estimate it for the association with mortality risk, if the negative, the impact on life expectancy is also negative, but majority of them are still positive. So over here, for the number 6 sub figure, you can see all of them impact positive, have the impact on life expectancy for those race-ethnicity subgroups. Next slide, please. Okay, so over here, I need to want to talk about 2 things. For the life table method, the population weighted estimates. So you use the reference population to identify the PM2.5 impact and estimate life expectancy through population weighted. But there's one thing, like when I was estimating, especially for the African American population, the younger age groups, the negative associated, but they are significant, very high when the older age groups. I was thinking, instead of using the population weighted estimate or to calculate the overall impact, how about we use the death profile? So what I also calculate another one is it's death weighted estimate. So for each age group, you have the PM2.5 impact, right? But you do not multiply by the population in that age group divided by the total population. I used PM2.5 impact times the deaths, number of deaths in that age group divided by the total deaths. So this is the death weighted estimate. Then it will identify, especially for those Black or African American race ethnicity subgroups, the burden, you can see the death or burden increase significantly. So I think this is the way what I made another analysis on the impact of PM2.5 on life expectancy. So basically, we have 2. One's population based, another one is the death weighted and this population weighted. So population weighted, like that's a typical life table methods. So it's representing the demographic structure. But when I use this to weight, so it's kind of produce a metric of mortality or burden. So just letting you know that 2 different weighting algorithms at its end. Okay, next slide, please. Okay, for this one, this is a summarize of the impact and also the policy effect. For the overall, we can see the this weighted PM2.5 impact is 0.61 in period number 1, and period number 2 in this weighted is 0.37. The overall policy effect is 0.24 based on the burden of impact. This is the overall, but if we do 5 age groups and 10 age groups, we see for Black Hispanics, they all have very high impact for this weighted for period 1. And then for period number 2, they are much smaller. That means that this for those those race ethnicity subgroups, they shifted, or they improved most. So you can see the Black Hispanics have the most policy effect due to the significant reductions of the air pollution. So that's the main research findings of this table. But doesn't mean there's no most of the impacts are significant. You can see the PM2.5 impact are significant. Most age groups and also the race ethnicity subgroups. Next slide, please. Okay, so this is a summary of PM2.5 association with mortality and also the life expectancy. As I said, if we put a period 1, period 2 together, all age groups have significant association with PM2.5 exposure on mortality, right? And also for the impact on life expectancy, there are significant with range of 0.16 to 0.95. For the second period, similar. Even though for second period, the levels of impact is getting is said over here, but in PM impact 0.29. Yeah, from period 1, if we go to 2 periods, period 1 and period 2, they're all almost significant associations. But the thing different is period 1, the impact is from 0.29 to 0.95. You go to period number 2, the impact becoming gradually smaller, 0.29 to 0.77. So when you do the race ethnicity stratification, they largely remain positive associated with the mortality and also for life expectancy. And they are also have significant impacts. So, and also the improvement, what we identify is from period number 1 to period number 2, the most of them showed improvements on the burden of deaths, except the other categories. Okay, next slide, please. Okay, how to get the analysis onto sensor tract. So basically, for each sensor tract, we have the total population for that sensor tract, right? Or we only pick up one sensor tract. Assume you have the total population, you have the age distribution, you also have the race ethnicity stratification. Then how to calculate PM2.5 impact on that specific sensor tract. So basically what we did is, okay, what's the PM2.5 impact for each race ethnicity on life expectancy, right? Then when we use that information, then the PM2.5 impact on life expectancy for that race ethnicity subgroup. So use the population times PM2.5 impact for that race ethnicity. And you go through every race ethnicity, not that, yeah. You go through every race ethnicity, then you calculate the total PM2.5 impact times all the race ethnicities, right? And divided by the total population. Then in that way, you calculate the sensor tract level PM2.5 impact. Okay, next slide. So this one, you can specifically see if we only did it two period to centennial, once 2010 and also 2020. Over here, we use the same scale from 2010 to 2020. You can see specifically, you don't really see the actual numbers, you just see the figures. The middle one for 2020 have significant improvement on PM2.5 impact. That means the PM2.5 impact is much smaller compared to 2010. The far right one is the comparison of the period. So that means the value in the first one minus the value in the second one, that's the middle one. You get the policy benefit. The policy benefit, most of them are positive, but still the some of the negative or very small negative ones or very small value ones, especially over here, I want to point out is the central king value still have another issue to deal with. Okay, next slide, please. So this is the summary of census tract level life expectancy impact from PM2.5. So this is only a numerical value comparison. Okay, you can see the overall policy benefit from period 1 to period number 2 is based on mean 0.82 to 0.61. Then the benefit would be 0.21. Do not treat it as this kind of stats because this is only based on the number of census tracts you can present, right? But some of the census tracts might be heavily populated. Some of them might be very low population. But this only gives you a summary of what would be the impact. But the figures I showed you before, the slide that shows you the overall impact or policy impact on the PM2.5 reduction, associated reduction in mortality, and also associated improvement of life expectancy. Okay, next slide, please. Okay, this I have done most of the talking now. We also did the community engagement through RAMP. Now I'm turning the slides to Joe.
Great. Jason, thank you so much. And thank you for this opportunity to participate in this webinar and this research project. First, I want to check, did I get a thumbs up from someone? Can you hear me okay?
Yes.
Great, thank you. So I'm Joel Irvis. I'm the Associate Director at RAMP, Regional Asthma Management and Prevention. Next slide, please. Oh, next slide, please. Perfect, thank you. So as I'll describe in the next few minutes, RAMP led outreach and communication activities for the project. What you're seeing here is the title slide from one of the webinars that we conducted. But first, just a bit more about RAMP. We are a project of the nonprofit Public Health Institute, and our mission is to reduce the burden of asthma with a focus on health equity. We don't provide direct service to people with asthma, but we support those who do. Emphasizing both prevention and management, we build capacity, create linkages, and mobilize networks to advocate for policy and systems change, targeting the root causes of asthma disparities. One of our goal areas, Healthy Air for All, focuses on the long history of inequitable pollution exposure faced by low-income communities and communities of color, which can exacerbate asthma and contribute to the onset of the disease. We're very excited to partner with Jason and the other team members on this research project. Next slide, please. So as I mentioned, RAMP led outreach and communication activities for the projects, primarily by leveraging our partnerships with asthma, healthcare, and environmental justice networks. As noted on the slide, the events that we hosted pulled in over 140 attendees and included community members, healthcare providers, environmental justice advocates, decision makers, and others interested in this issue. Next slide, please. We conducted a lot of outreach to ensure a high number of participants. RAMP leads several formal networks involving a wide range of people and organizations working on asthma from a variety of perspectives. We also have an e-newsletter that reaches over 1,200 asthma stakeholders, most of whom are here in California. So we reached out to these networks to invite them to participate in 2 webinars we held in March of 2024. Each webinar featured the same content with an overview of the study goals, design, and initial findings. We also reached out to our partners to leverage their own networks. So for example, the California Alliance for Children's Environmental Health advertised the webinar. We also plugged the events through the San Diego Tijuana Air Quality Task Force. The webinars were simultaneously translated into Spanish to support everyone's participation. I was particularly pleased to see a lot of representation from communities that are disproportionately impacted by PM2.5 exposure. And also, we had a really nice mix between urban and rural participants. Next slide, please. So the feedback we received about the study certainly confirmed its applicability to asthma and air quality related work. One participant noted, quote, "It is relevant in that I work with people who have asthma, and we also focus on trying to improve air quality inside the home," end quote. And as I'm sure most of you know, air quality inside the home can be influenced by the air quality that is outside the home. Another participant shared, quote, "PM monitoring is relevant for my research. I work with satellite air pollution estimates," end quote. There was also a lot of interest in disseminating the findings in a variety of ways to reach the public and policymakers. Ideas range from popular education materials, including flyers, news articles, and social media, as well as more traditional approaches like academic papers. So ultimately, many participants hoped the findings will help policymakers address pollution, particularly in highly burdened communities. One participant put it this way, quote, "Hopefully this will make policymakers rethink certain projects for the long-term effects and not short-term gains," end quote. And with that, I will turn it back over to Dr. Su.
Thank you, Joe, for sharing the community engagement part. You talked briefly, but it's tons of work, a lot of work. You have fantastic organization skills to get all the community members into your webinar, and those are fantastic. Thank you for the work you have done. Really appreciate it.
Welcome.
Okay, so now we are summarizing the entire project. So from Dr. Lee's literature review is basically conference. For the 31 studies, he summarized not majority of them showed a significant association of PM2.5 with mortality risk and life expectancy. And also the in all this study, we also confirmed that the PM2.5 exposure remains significantly associated with different age groups and also the race-ethnicity subgroups, but also have significant impact on life expectancy. But the thing is that PM2.5 concentrations have done significantly across the years, and this also reduced impact on life expectancy. Even though the statewide, the life expectancy reduced from period 1, 6.61 to period 2 of 0.37, the impact are not even. So for age groups, we can see the gradually change is the for the period number 1 is mainly at older age groups, but when you go to period 2, comparatively, okay, when you go to period 2, it's the younger age groups have greater impacts. For race, ethnicity, the Blacks and the Hispanics, they still have significant impact, but the benefit most from the reductions of regulatory monitors PM2.5 concentrations. So for census tract mapping, you can see it's similar. Right? From period number 1, it's significantly higher, and go to period 2, lower. And also the reduction of the life expectancy getting smaller in period number 2, but still the differential impact. Some of the places like Central King Valley are still significantly impacted. Okay, next slide, please. Okay, what implications for COP? So COP has done fantastic job throughout the years in regulating the air quality. So this higher created the reductions in mortality risk and reductions in life expectancy due to PM2.5 impact. So despite those overall impact, PM2.5 burden across race, ethnicity, and age groups, and also the sign of census tracts are still not consider a lot uniformly distributed. There's still those hotspots we need to pay attention to. Especially, I'm suggesting is the those census tract level mapping. I think that would be able to let a COP to identify those hotspots more clearly and find remaining burdens of hotspots and support fine scale evaluation or regulatory progress. So overall, with the support of everybody and also the support of COP, I think this is a very significant research finding for us, and also for California Air Resources Board to take action on future efforts to reduce air pollution and improve people's health. Next slide, please. Okay. So I would be thankful for COP's funding. Without your funding, it won't be able for us to do anything this significant. I'm also grateful for John Bourne's support. John is my academic advisor. He's always be over there whenever I have anything I need help from him. John is COP board member, but also the physician. He knows deeply about the impact of air pollution on health, various health. And also I'm thankful for Dr. Lee's needed review. Dr. Autumn Pope and Dr. Rob McConnell. Those two are my academic advisors for long time. They are the people with the most knowledge on this aspect, and grateful for the commitment and help throughout the project. So for the UC Berkeley research team, I also have my postdoc, Isham Shehari. He did some fantastic job in the modeling part. I also have two research assistants. One's John, another one Disha. I know they're done with the courses right now. They're probably somewhere in the country. Thank you very much for your participation for today's presentation. Really appreciate your time spent on this. Thank you.
Thank you, Dr. Su, for the great presentation, and thanks also to your team. Now we will be taking questions. So you can raise your hands, or you can put question on the chat. I see. Okay, Jeff. Yeah, I have unmuted. Can you unmute? I have asked for. Yeah.
Hi there. So this was very interesting. Just quick, so you understand where I'm coming from. I serve on the AB 617 Community Steering Committee for the Richmond, North Richmond, San Pablo area. Richmond was one of the first 10 AB 617 communities, overwhelmingly because we host the Chevron refinery, which is the biggest refinery in on the West Coast. And when we look at our health issues, what we really need the focus to be on, much more than mortality, honestly, is chronic health. So I'm curious what, if this study tells us some things about, mortality, how can we rejigger this study to give us better information about chronic health, the daily experience of living in a polluted community. I mean, we see stuff every day, whether it's the amount of soot on our cars in the morning, or whether it's the number of kids in an average high school classroom with 30 kids, how many of them are on inhalers? 5, 6, 7. It's not like we don't live in a community that looks like Palo Alto, if you know what I mean. So it's not about, for us, we know it's not about, freeways. It's not, I mean, that's part of the mix. But, we know that it's a lot about the refinery. So this presentation sort of doesn't help us advance our efforts to reduce pollution and to be as focused as possible on the pollution that might be possible to reduce coming from the refinery. So in that sense, I want to support census tract information and I want to support not just NOx and ozone and PM2.5, because we've got sulfuric acid and hydrogen chloride and nickel and manganese and a lot of specific tax that come with the PM. So I mean, I think you get the idea. I'm just curious how we can get more focused on the actual public health problems of the most polluted communities.
Thank you, Jeff. Really appreciate your input. I'm not sure I want to talk about this. COP is doing a fantastic job. There's so many things to work on for the people, right? There's so many different issues, especially I agree with you for Richmond. I'm not far away from Richmond, by the way, for the refineries. So those are the people being exposed to those the plumes and also the gases daily and nightly, especially during the invasion, you can smell sometimes. But probably Bonnie can help respond to that because she is a research chair. She knows what's the direction. We also have some other research projects being funded by COP. Well, I think Bonnie can take on that.
Yeah, Bonnie, I unmuted you.
Yeah, and I think we probably need to do a general unmute so that Dr. Balmes and Dr. McConnell and other consultants, other advisors on this project could also jump in if they want. I just wanted to thank you for your participation, Jeff, and your comments, and just to assure you that CARB has a very, I think, a very important and extensive research program on the health impacts of air pollution, and we're looking at all of these different kinds of health impacts. Life expectancy is, of course, one important aspect, and we're really pleased with the study that Dr. Su and his team have completed. But we've also been working very hard to update our understanding of the health impacts across the board on asthma and respiratory impacts. We've been looking recently at, we have a study that's Dr. Su helped just complete on metabolic impacts, including diabetes. We've been focused on brain health impacts, neurodevelopmental impacts and neurodegenerative impacts. We have a wide swath of research going on, and all of this is feeding into helping us to better quantify and characterize the health impacts of air pollution. And we do that to help support all of our programs and projects at the board, and of course to help support important health-based air quality standards at the national and state level that help promote community health. I'll turn it over. Looks like Dr. Balmes might want to comment.
Thanks, Bonnie.
Yeah. Thanks, Bonnie. And Jeff, I totally agree that the community steering committees that represent the communities that are designated as AB 617 communities are more concerned about immediate and present health impacts of air pollution in their communities rather than mortality. For this particular study, mortality was the sort of best outcome to look at across 3 decades. But I just want to assure you, as a longtime collaborator of Dr. Su, he's done more studies with regard to acute effects of air pollution, especially on asthma, than mortality studies. So he's well aware of your concerns, like he said. And I just want to assure you that as a longtime physician member of the Air Resources Board, who's particularly interested in AB 617 communities and the disproportionate burden of air pollution that they experience, that we're very aware of your concerns. And as Bonnie said, we're trying to support research to address those concerns.
Thanks, Dr. Bones. Dr. Enstrom, I unmuted you. Can go ahead and ask your question.
Thank you. I have submitted a number of things relevant to this seminar. I submitted a proposal of my own back in January of 2023, and I've also sent email messages in 2024 and last week to Dr. Su, and I have not received any response. I think it's really important to understand how controversial this is. And maybe Dr. Lee could engage with me. This involves the fact that he cut off the searching at 2000. The controversy on PM2.5 deaths goes back into the 90s, particularly it's over 30 years. And Dr. Su has not mentioned the word controversy anywhere in his report. I've looked at his final report. There is also in the table that was presented by Dr. Lee at the beginning, he goes 31 studies. They mentioned my study in 2005, but not my study in 2017 and 18, and numerous other studies that show no effect in California. In fact, most of what is in that table is not relevant to California. There are major studies in the state of California which show no relationship between PM2.5 and total mortality or life expectancy. And none of this is cited by Dr. Su. And Dr. Su also was involved in a very controversial study back in 2011 that was headed by Michael Jarrett. This is a report that was focused on the American Cancer Society CPS-2 study looking at mortality in California. And that study was heavily criticized by me and numerous others. So I think it's really important that CARB, if they want to do what's in the best interest of California, now that we have among the lowest levels of PM2.5 in the entire world, that they take criticism seriously and they respond to critics. So this would be either for Dr. Su or Dr. Lee. I would like some type of response. Thank you.
I'm happy to jump in. I mean, I think, so first of all, Dr. Enstrom, thank you for bringing those things up. I will say the specific studies that you mentioned, I have to say, I do not recall the reasons why the more recent studies were excluded. It may have been through whether they were specifically cause-specific mortality. I do not recall, and so I should not conjecture. I will say, I mean, I think on a more overarching level, I think, one of the results that Dr. Su, that, I've seen various versions of Dr. Su's presentation and that I think it does bear out, and I would, maybe this is a somewhat puckish comment, but has CARB been so successful that it is putting itself out of business? I mean, I think the really interesting thing is if you look at the mortality effects and the life expectancy effects from 2000 to 2010 versus 2010 to 2020, I mean, we are getting to the point of lower marginal benefits with additional decreases in pollution. So I think there are those questions, and I think as the previous commenter mentioned, there are many other effects of air pollution that I think are being disproportionately felt in certain pockets in the state. So I think there's still a lot of work to be done, and I certainly appreciate some of the other specific points, and we can get back to you about your specific studies that why those were excluded. But I appreciate your comments, and I think there's other important work to be done. And I'll leave it to Dr. Su to address some of your other questions.
Thanks, Dr. Lee. Dr. Su?
Dr. Su, did you want to comment on this also?
Oh.
Is
Dr. Su?
he still on?
Listen?
I would just...
If he...
Yeah.
Oh, there he is.
Yeah, Dr. Su, yeah.
Okay. Can you hear me now?
Yeah.
Yes, we can hear you.
Hi, James. Nice to meet you. Have we ever met? How do you? Can you do a little bit introduction of what you have been doing? Because I got quite a few emails through you for the last few years. I really wanted to know the criticism you have on me for the last few years. If you could do an introduction, I might miss something, then I would know, then we would have a better conversation.
Well, I don't know if you carefully examined the emails or not. I've described myself. I've had a career as an environmental epidemiologist at UCLA that began in 1973. And I've published a number of important findings that are relevant to environmental epidemiology and lifestyle epidemiology. And in particular, I have communicated with CARB now for over 20 years regarding the evidence that there's no relationship between PM2.5 and total mortality in the state of California. And this is backed up by several other studies conducted by other investigators. And it's important for you to understand this, and especially the study that you were involved with Michael Jarrett using the American Cancer Society CPS2 database. This was, on the order of 15 years ago, but it's highly relevant to what you're talking about now, because this is the major study that started this whole notion of PM2.5 deaths. The American Cancer Society CPS2 study, when the publication with Arden Pope, who's been a consultant on this, he's very well of the controversy that exists now for over 30 years. And you don't, in your final report, you don't mention the word controversy. I did a word search. There's not one time where you mention controversy in 130 pages. So I don't believe that you are fairly representing the evidence that exists in the state of California. I don't care what the evidence might show in other parts of the world where they have much higher pollution levels. You look at a map of air pollution in the United States, and we're at the low end in the entire world. So this is the wrong place to focus efforts. And
so I just wanted to jump in and just say thank you, Dr. Enstrom, for your comments. We're going to move on to some other comments. I am a branch chief in the research division, and we have responded to your comments. We have gotten your
It's not accurate. That's not accurate.
We're going to have to, I'm sorry, we're going to have to mute you because we have to have an orderly discussion
right.
here. And we have other people that need to contribute. And I wanted to say that we have responded to your comments, and other researchers have responded to your comments. And we do believe that
That's a
Dr.
false
Su's
statement.
representation is Dr. Su's study is a very fair representation of the research, and the introduction provided a very fair representation of the significant body of global research on PM2.5 and mortality. And we're building on a very strong, very solid and well-researched base of literature on PM2.5 and mortality. And I think, as expressed by an earlier speaker here, all the effects of air pollution, both chronic effects and mortality effects, are being experienced across California. And it's very important for us to better understand, and especially understand where disparities are occurring so that we can respond. So I wondered if Dr. McConnell also wanted to respond on this topic, and maybe he is one of the research advisors, and I can't see if he still has his hand up, but I wondered if he might make a few comments, or John Balmes, and then we can move on to maybe we can go then to the questions in the chat, and then go back to the online speakers.
Thanks, Bonnie. Dr. Rob McConnell, I have unmuted you.
Yeah, thank you. I mean, I'm not going to address the specific comments, but I think there's, as to the overall question of whether air pollution increases mortality, there's a very robust body of data that shows that to be the case. Many studies, some of which were presented here today, you could see many meta-analyses that come to the same conclusion. There are animal toxicologic studies that are consistent. There are new studies that show effects along pathways, genetic variants that are consistent with a causal inference. I think it's a stretch to say that there is uncertainty about this association. There are many unanswered questions. There are many research questions that merit investigation, but I don't think there's any question. I think that one of the strategies of pioneered by the tobacco industry, but that you see across a lot of research questions, is to manufacture uncertainty, and that's a strategy that leads us to not doing what we need to do, which is to regulate environmental toxins where the database is well established and there's good evidence in order to protect the public. So I would reject the premise out of hand that there's uncertainty to the causal relationship between PM2.5 and mortality.
Thanks.
Thank you, Dr. McConnell. Let's go, Nargis, to the comments in the chat, and then get those answered, and then we can go back.
Okay. There is. Okay. There was a question for Dr. Su, but one question with regards to spatial representation in areas with low population density, like the rural areas, towns in the mountain. How did you deal with, especially for some small areas and age groups, and more uncertainty about the ambient concentration? Dr. Su, are you unmuted?
Okay. Thank you. By the way, when we go to census tract level, that's already done with all the modeling, right? When we didn't model to the census tract level, like for estimating the PM2.5 impact, and also the mortality, but also the life expectancy. Those are modeled specifically at age groups and race-ethnicity subgroups across the entire California, specific to time periods. When we go to the census tract level, the exposure, what we use is not the, I totally agree. Census tract zip codes, you go to rural areas, are huge. What we did was we used the block groups, weighted centrally. So like you have one block group, a lot of population over there, then it will be weighted much bigger based on the proportion. You have 90% of the population within that very small block group, then the weight will be linear over there. So that's what we did for the calculation of the exposure of the census tract, and also the once you go to the impact is also based on the census. It's basically a block group weighted centrally to get the results, even though the results representing the same census tracts, but the population weighted based on where people live.
Thanks, Dr. Su. There was one question for Joel and Ram. Do you have data available to see how asthma case increase or decrease last 10 to 20 years, how it related to PM2.5, and how services have been improved in recent years, especially for high impacted ethnic groups?
Sure, appreciate the question. So I did reply in the chat. Just to recap, I don't have those statistics right at my fingertips, but I know it's just one example that asthma-related hospitalizations have gone down over the last several decades, which is great. I think that there are likely a lot of different reasons for that, and I would like to think that the reduction in PM2.5 would be one of them. RAMP is not a research organization ourselves, so we haven't been able to look into this issue directly. It's one of the reasons that we appreciate opportunities to participate in research projects like this, and also certainly appreciate all of the other research on this issue that CARB supports. I'll just say too that, I think in terms of identifying and working on pollution, particularly in inequitably burdened communities, there's still a lot more work to be done in that area, but we're also seeing, I think, really good progress. The AB 617 communities have been mentioned, where you have very, very local approaches to reducing air pollution. Things like that are great. We're seeing a lot of work on the incentive side, so incentives that are being distributed for zero emission vehicles and other sources of pollution that target overburdened communities. And I think we're also seeing more work on the regulatory side, where policymakers are realizing that pollution is not distributed equally, and so regulations also need to address the cumulative burden from pollution in new ways. Thanks for the question. Appreciate it.
Thanks, Joel.
Nargis, I just want to jump in and ask one question, and then we'll go to the last few. I just don't want to miss this important aspect of the study. Apologize, Nargis, for jumping in here. When the study found that a particular impact in younger and middle-aged groups having more life expectancy related impacts in period 2. And I wondered if the research team could address what this finding is telling us about the changing impact of air pollution on communities as we are achieving, as the study shows, we're showing a lot of success overall in reducing PM2.5 mortality, PM2.5 and related mortality impacts. We are still seeing disparities, but we're also seeing this change in terms of which age groups are experiencing these impacts. Dr. Su or your team or advisors, could you address what this is telling us?
Thanks, Bonnie.
I could do a little bit, but I think my academic advisors have more to say, for sure. One thing is that from 2016, 2017, I think it's the Obamacare, those basically Medicare expansion probably extended significantly to those old age groups who have better health care. The air pollution impact might reduce somewhat. For the younger age groups, when you go to period 2, I'm not sure specific. It's that because the air pollution levels are lower, significantly lower than the first period, is that the more activities outdoors. So it's because the nine young nuns and those might have the impact on those conditions or some other things. Probably I don't know. But I'm leaving to my academic advisors, John Burns, Rob McConnell, and they might have much better knowledge than me to say about this.
John, can you address that? I know, or he's muted. Okay. So can we unmute, please, John and
okay.
Rob McConnell, just in case they would like to make comments on this.
They're unmuted.
Okay.
Can you hear me now?
Yeah, I can hear you, Dr. Baums.
Well, I don't have that much to add to what Jason said. I think it's Bonnie and others. I think it's an interesting finding that in period 2, there's greater impact on younger and middle-aged individuals. There's still a great impact on the elderly. Just that there was a greater increase or a greater risk in period 2 than period 1 for the younger age groups. I think we don't really understand that at this point. It's one of those interesting findings that needs follow-up. Jason suggested some possible explanations, but at this point, that's speculation. So
Dr. Baums, I think you accidentally muted yourself or were muted in some way for the last
you
maybe.
Guys didn't hear me?
We heard the first part, but not the second. Yeah.
So where did I leave off, Joel?
You were talking about needing some additional study of this issue because
I think this issue should be pursued either by Jason or others. And I think that maybe Dr. Lee has something to say because he raised his hand during my comments.
Yeah, Dr. Lee.
Yeah, I was going to say, well, first of all, I agree with everything that Dr. Baum said, and I will make a meta comment of like, in a such esteemed company, all I have to do is stay quiet, and whatever I'm thinking is going to be said by somebody else. So, I mean, I would just say that this study cannot answer the question that Bonnie posed of, this is interesting, what's causing it? We can, as Dr. Baum said explicitly, conjecture on what it may be. I wonder about things like over the past 20 years, there's been a lot of focus on improving cardiovascular risk measures. And so basically, the JNC guidelines keep decreasing the blood pressure recommendations. Statins are now generic and incredibly widely used. And so all of those things are going to be decreasing, cardiovascular mortality, which is a big component of how air pollution leads to death. So, that could be one thing. There's been kind of this ongoing decrease in tobacco. And so there's many potential reasons why in the elderly population, it could be generational effects of, the people who are in their 70s and 80s or in the earlier may have had more lifetime exposure to, for example, tobacco than the current generation who are approaching their 70s and 80s. So I think the decrease of effects in the elderly population may be due to some of those things. But again, just to reiterate, this is all conjecture. these are kind of hypothesis generating. We found a very interesting finding, and now it is time to kind of explore with different types of studies what may explain that interesting finding. As a geriatrician, I will say my bias and my thinking naturally goes to the older adults, and so I will actually not say anything about the interesting finding of increased potential risks for the younger, for the pediatric population and the middle-aged population.
Thanks, Dr. Lee. Dr. McConnell, do you?
I don't have a lot to add to that. I think these are quite interesting suggestions for why we're seeing this. And I'd just point out that, this is quite an unusual study. It's large enough that you can look at risks of mortality in people who are under 25. That's quite unusual. And to be able to look across the two periods, I don't know if it's unique, but there aren't very many studies where we could compare what's being seen here with what's been seen in other studies. And it's a case where further research is needed.
Thanks, Dr. McConnell. We have a few hands raised. Stan, do you want to? You are unmuted. Yeah.
Yes, I'm an applied statistician. Can someone raise their hand that you can hear me? Can you hear me?
Yeah, we can hear you.
Okay. I had the opportunity to look at California data, 2000 to 2012. We had 37,000 different exposure days, and we looked at acute effects, adjusted for location, things like that. And we looked at different age groups too. We essentially found nothing. We looked at 96 different combinations of PM, ozone, age, different causes of death. And if you look at that carefully, we didn't find anything. We also ran a study looking at different factors that might have influenced the analysis. We ran over 74,000 different combinations of things in a sensitivity analysis. If you go back to the Dockery study, they made a claim of a risk ratio of 1.26, which is quite high and was very startling at the time. Orlando, latest estimates, put the risk estimate at 1.0026, which is very, very small. So my question, I'd like to get the data from 2012 to 2021 or whatever and run it back through my methods and see what I can find. Other people have duplicated my results, and in fact, we published our data, made it public in 2015, and so far nobody has contradicted what we did. The question in my mind, the crucial question is, if the risk ratio is as small as Orlando says, and my indicates support him, then the risk ratios that are being shown here are quite a bit higher than that. And so what sources of bias could be in the data that give these higher ratios? Is the data itself that Dr. Su has presented, there's something in there based on his analysis, but it it conflicts with data that I've done. My results have been duplicated 3 or 4 times, even with much larger data sets. So there's a conflict between very, very small acute risk ratios, which, if there's no acute effect, how can it accumulate over time is one question. And then the other question is, what are the sources of bias that cause the discrepancy between these results. And I could talk about asthma too. I've looked at that, but that's a very complicated thing. I won't go into the things on asthma, but the death rates are quite startlingly different. Even California is blessed with forest fires, and so the forest fires put out PM2.5. It wafts across Los Angeles. PM goes up, deaths do not go up. So there's some questions that are unanswered here on the basis of what's going on. So I'll stop there.
Yeah, I would really appreciate your comments. This is what we always want to answer, right? For me, what I have been doing for the last 10 years, I started an exposure assessment based on the proximity. So I think what the bias over here, what I can see, that's why I'm focusing on for the last more than a decade, try to improve the exposure estimate. So I think large majority of the studies are still using very crude interpolation or proximity analysis. Those are not the real exposure as what I'm thinking, and that's what I have been doing for the last decade, trying to reduce exposure misclassifications. That's why the models, what we develop, are at a centimeter resolution, but we output to 100-meter spatial resolution, like a Dani, even though the Dani still have the bias, right? But that should be good enough to get rid of most exposure misclassifications. I guess the exposure, what you used, the very, very crude exposure estimates. Everybody knows that the PM2.5 exposure might have regional patterns. What you have done, you are using only regional. I understand that the PM2.5 exposures have reduced for LA, but those hotspots still remain. For you could not identify those ones. I think that's part of the reason the bias still exists over here. That's also part of the reason what I have been working on for my research.
Thanks, Dr. Su. Hey, we are going to move on, and we are at the end of our time, but we want to extend it just for a moment. So thank you, Stan Young, for your comment, and it was responded to by Dr. Su. We have one more hand up, and we have Dr. Lee also, but Charles, you want to give your comment? And I think we really have about 2 minutes for a comment or question, and then we'll go to Dr. Su and the team if they would like to respond to. Oh, we have Ian too. Yeah, we have two people. So if we have 2 minutes each, we have 2 questions. Let's put the questions out there, and then we can have Dr. Su and his team respond to those questions and also respond to the questions in the chat asking for elaboration on the policy benefits of this study. So Charles McGaw, do you want to ask your question?
Yes, I'm assuming you can hear me.
Yes.
First of all, I'm very glad that I attended this discussion, and unfortunately, it reinforces some of the negative impressions I've had about how we make decisions in California. First of all, why wasn't it? I couldn't find the data beforehand, so I could go through it and really ask some relevant questions. So could you please present data beforehand? Secondly, I don't like the way the data was presented. It's hard to pull out what you're trying to say and in the amount of time and this chart selection, but that's not my major problem. Towards the end of the discussion, we had some other information being presented regarding PM2.5 and the effects of PM2.5. Just to be clear, I think we really need to focus on what we mean by hotspots. I'm familiar with the MATE studies, and the MATE studies are saying that we have reduced 2.5 level to very low levels, and the MATE studies themselves indicate that the risk from PM2.5, which is the highest risk to health in the Los Angeles region is at its lowest level since then. Question is, what are we going to do? I mean, are we going to change the PM2.5 concentration in an urban area over the next 5 years? We've gotten all the things we can do. We've gotten the low-hanging fruit. I mean, we have Teslas, we have better cars. What are we going to gain? What is the bang for the buck? And also, what are we going to gain in terms of life effects? It's 0.37 years. What good is that if you spend the last 0.37 years, you've gained flat on your bed in a ventilator in some hospital? So I really want us to start focusing on hard data. What can we do? Take into account mobility. You use the word misclassification. Location misclassification is something that's important. We are a very mobile society. What is impacting our air and what can we do from a budget point of view? This has just been a fest of who can get out the most terms like hotspots and environmental injustice terms and things like this. Do hotspots really exist? And can we do that? The MATE study and the CARB study of the Inglewood area suggests that there is no significant difference in the air quality for PM2.5 from across that section of Southern California that was part of that SNAP study. So I think we really need to stop using terminology from the late 70s and 80s and actually do some measurements where we measure that and see, do we have hotspots and can we mitigate that? Because we've done a lot. What benefit did we get from that?
Thank you very much for your comment. And we obviously don't have enough time to go into detailed responses, but really appreciate your comments. Let's go to Ian McMillan and see what your question or comment is.
Hi, can you hear me?
Yes.
All right, I'll be quick. Thanks so much. Really appreciate this. Very interesting research, looking to engage more on it. Clearly, there's some challenges left with PM2.5, including here in South Coast. That's where I'm from, South Coast AQMD. Just a quick question. This is more for CARB, just on process. So what comes next? Because I think there are, we're seeing this for the first time ourselves, understanding this is going to, peer review, I think probably as we speak. I think there's a lot of details in this. I'm just trying to figure out, so what are the next steps on how to engage and trying to see, what does CARB plan to do next with this?
Thank you. I mean, we're going to be posting the slide. This is a research contract, and we're going to be posting the slides and the presentation on our website. We're, of course, going to be continue to share the information and use it as a basis for determining what additional research is needed and to support the work that we're doing. Dr. Sue and the research team, I know, have been pursuing different venues of publication. So this is an important part of a much larger research program that is supporting the work of the Air Board. And if there's we will be continuing to look at these results, particularly with regard to the fact that it's pointing to disparities and impacts and how we can best address those as we go forward. If you would like to have a discussion, a more focused discussion on this study, we would be happy to schedule that, and maybe that would be a good idea. We'd be happy to either in regular meetings that we have, or we could set up a separate discussion to talk about this important research and the implications of the research, and what are the policy implications. So we'd be happy to do that.
Thanks so much, Bonnie. We'll just take the two questions in the chat.
Yeah, let's do the chat, and then let's let the research team respond. Thank you, Ian.
Thanks, Bonnie. Given that we have seen how pollution from the shipping industry has impacted mortality rates in port communities, can this study be used to support initiatives focusing on mobile sources like ships in transit, where the majority of pollution from ocean-going vessels originates from? Any of the research?
Or maybe you can just take both of these together because they're both talking about policy.
The next question is about policy. Can you please elaborate on the policy benefit, years of life saved? Does the policy benefit analysis specify whether policy analysis specify whether policy benefits were CARB specific policies only, or those adopted by census tract and also CARB? So Okay.
For our modeling process, we incorporated the impact of the ports. So those port railways, so sources are all included over here. So and also ocean-going vessels. Those are part of the modeling process. But I really want to focus on our study compared to those 70s, 80s. We are focusing on local variations of pollutant concentrations. For the early studies, most of the time they just use proximity or just purely interpolation. They didn't consider the impact of the sources from the ground. So that's the thing I've been working on for the last decade.
Thanks, Dr. Su. Okay, I think.
Yeah, I would just add that we have a number of other studies. There was a question around port communities, and in fact, Dr. Su helped us with a study, not specifically looking at mortality, but looking at impacts of asthma medication in port communities, and we saw, unfortunately, very significant increases in asthma medication use in port communities. So just as underscoring the fact that we are doing research to look at other health outcomes and to look at communities that are highly impacted. And I think that all of this research, including this research on mortality and life expectancy, is helping us to better understand where we are experiencing the benefits of our policies, and is giving us important evidence that shows the importance of redoubling our efforts to continue to reduce particle pollution, particularly in the most impacted communities. So we really appreciate the study as adding to that broader effort. Nargis, are there other comments we want to address?
Yeah, this is not a question, it's more of a comment. Maybe the reason we don't see more PM impact because of the 20 top toxic air contaminant, then PM, and there is if black carbon is also impacting. So it's kind of a comment then of a question. So
any comments, Dr. Su or team comments on that? Other pollutants, I mean, clearly we only looked at PM2.5 in this study, and there certainly are other contaminants of concern.
Yeah, for me, I think a PM2.5 is significant because it's based on the toxicity of the PM2.5, right? I think NO2 is also an important pollutant, even though people might say that's a proxy, but NO2 specifically reflects a significant impact of traffic and traffic related for people. And in North America, most significant impact from traffic. That's why we are focusing so much research on impact of traffic. For those people living close to the highways, the traffic marker NO2 might be a very good indicator to research on the impact on people's all sorts of health concerns.
Thanks.
Thank you, Dr. Su. Let's go to Dr. Lee, and then I think we're going to have to close because we are 10 minutes over. If anybody else has comments or questions, Nargis will give her email at the end.
Okay.
Dr. Lee?
Yeah, I mean, I just wanted to address the question about the port facilities and from Mr. Kilbreth. I think both of those really point to the fact that there's many types of air pollution, and as scientists, I think we necessarily focus on a reductionist paradigm of, okay, what is the exposure we're interested in? And we can't study everything. And so we focus on the most likely causes, and PM2.5, I think, is a very reasonable thing to focus on because it's so common and because there was this. And I think what other people are talking about is, what about all the other stuff? I think Mr. Kilbreth talked about, what about the hydrochloric acid and all the stuff that is being emitted by the Richmond refineries? Obviously, port facilities are going to have many other types of pollutants. All of those are really important and interesting questions. And as unsatisfying an answer as it is, outside of the scope of what we looked at here. And I think those are clearly things that we should be focusing on. The final thing that I think the previous one of the previous questions was about not finding any acute effects and how could that lead to chronic long-term effects. And I would argue that certainly from a health perspective, stuff like that happens all the time. Like where, you know, high elevated blood pressure does not usually does not lead to any acute effects, but over many decades that can cause huge increases in health outcomes. So just because we don't see acute effects at a certain level does not mean that it's not doing some sort of slow subclinical damage that over the course of many years or decades can lead to really appreciable health outcomes. So it's I think again, going back to my basic point about science, we need to be very clear about what question we are asking. And this was specifically a question, our focus was on PM2.5. And so all those other things are good questions, but not the question we were trying to address. And we were specifically tasked with long-term outcomes with PM2.5. And so that's why some of these other questions that came up, I think they're important questions, but there's a slightly different one than the ones that we were tasked with addressing.
Thanks, Dr. Lee. Yeah, we are way over our time. So thanks everybody for joining today's seminar. Have a good rest of your day. I have to end the seminar. You can send, if any additional questions, I have put my email address, so you can email me. Thank you, everybody.
Thanks, everybody.
Thanks.
Have a good day. Bye-bye.
Thanks.
Thank you.